Hi, everyone. I am Kate. I am the Vice President of the Minnesota Endo Warriors. We're really excited to have you guys on this call today, and we're really excited to have Dr. Cope and Dr. Burnett joining us tonight. So I'm just going to tell you guys a little bit about each doctor here. So Dr. Burnett is an assistant professor in OBGYN at Mayo Clinic in Rochester. Following medical school and residency at the University of Michigan, he completed a 2-year fellowship in minimally invasive gynecology surgery at Southern Illinois University before joining the faculty in his current position, and holds joint appointments in the Department of Obstetrics and Surgery. He is board certified in obstetrics and gynecology. Clinically, Dr. Burnett specializes in minimally invasive gynecological surgery with a focus on endometriosis and pelvic pain. He coordinates a complex endometriosis program, the center of which is an sorry, I'm like choking on my words today, sorry, is an interdisciplinary MRI and endometriosis conference co-chaired with radiology that has advanced endometriosis care at Mayo Clinic. His research interests include endometriosis and its relationship to varying patient phenotypes and its coexistence with other pelvic pain generating diseases such as adenomyosis. He is actively involved in education, training, residents, and fellows. So welcome, Dr. Burnett. We're excited to have you. And then we also have Dr. Cope, who is new to the Minnesota Endo Warriors. We're really excited to have you. So she is board certified OBGYN specializing in minimally invasive gynecological surgery. Her clinical interests include multidisciplinary care for complex benign gynecological pathology, including endometriosis and uterine fibroids, and advancement of minimally invasive surgical techniques and surgical education. And she also is interested in the promotion of enhanced recovery following benign gynecological surgery. In addition to her clinical activities, Dr. Cope is active in clinical research with multiple peer-reviewed publications on endo and uterine fibroids. She is passionate about medical education, serving as a teacher and mentor for medical students, residents, and fellows. So welcome. We're so excited to have you guys here. Thank you for joining us. So I'm just gonna hop right into the questions here. What led you guys to treating patients with endometriosis, and what drives you to continue since it's such a challenging disease?
Sure, I guess I'll start. Thank you for the invitation. It's a pleasure to be here and join this organization for a little chat. We just really appreciate all the patient-centered organizations that assist our patients, our people who have endometriosis or other disorders, and are here to support them and provide community and provide support and direction. So thank you for being here. What led me to specialize in treating this pain condition? Really, honestly, after doing obstetrics and gynecology residency, pelvic pain was just one of those areas that I felt was very underserved. I was fortunate enough to train in a program that had a very good pelvic pain center. So I learned a lot of pelvic pain techniques as a resident, but endometriosis care really wasn't something that was, I would say, done with excellence. And as I went through fellowship and saw how other people were doing endometriosis, I learned more about that. I combined that pelvic pain focus with appropriate endometriosis surgery. And again, the biggest reason, honestly, is I just saw so many women who were not getting the care they needed. I saw that there was a big vacuum in providers who are providing the appropriate type of care, even just for pelvic pain and endometriosis itself. So it just seemed a place that I could throw my hands in and help out.
I second Dr. Burnett. Thank you so much for including us in this discussion today and for hosting us. We're excited to be here with all of you. And really, my story is very similar to Dr. Burnett's. I did my residency at Mayo Clinic in Rochester, Minnesota, and then I was fortunate enough to be invited to undergo additional training and then stay on as faculty. And a big part of my interest in endometriosis and taking care of patients with endometriosis and chronic pain is just as Dr. Burnett said. I think that there's a great need in this patient population, and it's something that allows us to help not just, provide care, but also specialized care in an area where there is desperate need for it. And so allows us to be an advocate, allows us to be busy in terms of surgery, but also building relationships with patients, which I think is something special about OBGYN in general, but then in particular about taking care of patients with endometriosis. And I think that part of what keeps me going with it, that was another part of the question, is that it's exciting to see that there's advancements in the field all the time. I know that it's slow progress, which can be frustrating for providers and for patients alike, but I think that it's an area where advocacy is important, and that fills my need for having not just a job, but also really a vocation, something that speaks to me as a person. And so that's part of what keeps me going within the field too.
Awesome. Thank you for that. So can you guys kind of touch on the multiple disciplinary like team approach that Mayo uses for seeing patients with pelvic pain, and who all is involved, and other professionals like PT, nutritionists, kind of stuff like that?
I'll let you take first stab, Dr. Cope.
Sure. So, when we think about chronic pelvic pain and endometriosis, it's oftentimes not just one pathology that we're addressing. And I think that part of what makes our practice unique, and part of what we're very grateful about with it, is because it is complex. We're able to work with multiple different teams to fully combine those resources to provide complex continuity of care for patients, and also address all of those components of someone's overall pain picture and just overall health picture too, because this can also occur in patients who are otherwise medically complex with other underlying medical comorbidities. And so being at an institution like Mayo allows us to work with multiple subspecialties to provide complete care for patients. Part of what that looks like in terms of the pelvic pain side of things, there's a couple of different avenues that patients come to see us as surgeons for endometriosis. One of the more complete ways is through our chronic pelvic pain clinic. We work very closely with our support staff. There's nurse practitioners that work with us. And what we do as a group is we start with intake, kind of getting a sense for what are all of the different parts of a person's care we're going to need to address, to really make sure we're not leaving anything behind, and that we're fully addressing each of those components of someone's pain and health picture. Part of that assessment involves an exam, going over imaging, and then talking broadly about what the overall pain picture looks like for a given patient, and really trying to individualize it. Once we've done that analysis and that assessment with the patient with shared decision making, get a good sense for what goals are, that helps guide kind of what other consults we place after that. That can include working with other subspecialties outside of OBGYN, including gastroenterology, sometimes cardiothoracic, sometimes colon and rectal surgery, sometimes reproductive endocrinology and infertility. And with all of this too, we work very closely with radiology. Dr. Burnett, part of his area of interest and part of something that he's built since coming to Mayo was a really close relationship with radiology. And that has allowed us to advance our practice and really inform patients and also providers when it comes to making choices about next steps for care and surgical planning. And kind of going into that, Dr. Burnett, I'll let you talk about that, because there's been a lot of advancements in that area within our group as well recently too.
Sure. Yeah. Just to add to that, thanks, Dr. Cope. Really, endometriosis care is particularly centered around imaging. Now, while imaging still has a lot of gaps as far as identifying certain types of disease like superficial disease, when it comes to surgical planning, doing the right surgery for the patient in one sitting, I think really is optimal, so that we know all of the deep disease, all of the bulky disease that needs to be addressed, and we have the right team to do it at the time of that surgery if we plan for surgical treatment. Unfortunately, I wish I could say that you could go anywhere and someone could order a pelvic MRI and you would get the same results. That would be the ideal state for all patients, all around the USA. Unfortunately, it's not, and it's a complex question. It's not just having the right scanner or the right strength of scanner. It's how the scanner is protocoled. It's who reads the scanner. It's what medications are given at the time of the scan. And that's in regards to MRI. And then there's also ultrasound. Just a regular ultrasound doesn't typically show most of the deep endometriosis, but we can develop advanced ultrasounds that really can pinpoint deep endometriosis and map out the disease similar to MRI. So both of those technologies we are advancing here at Mayo Clinic because we work very closely hand in hand with other departments like radiology, and enable us to really do as complete a surgical planning job as possible if we're going to surgery, or if we're not going to surgery, to be able to determine, is there follow-up necessary? Do we need to do additional imaging? Do we need to keep an eye on something? So we really work closely with our radiology colleagues and the other colleagues who we operate with or otherwise manage with. And that is very purposely done proactively, and we are always collaborating kind of directly with them. So we're very happy with our collaborations with radiology, especially. We are pushing that forward all the time. We work together very closely, and I think that's really one of the benefits of what we can offer at Mayo Clinic.
And physical therapy too is something that is very common that we are referring patients for. We have that within our own group at Mayo Clinic in Rochester, but for destination patients, it might not be possible to come to Mayo for physical therapy. And so part of that initial assessment with them is also kind of making a game plan for what's actually going to be feasible when you're going home. And so figuring out if you have someone closer to you that provides that same service and working to make a game plan moving forward for the pelvic floor component of all of this as well.
Awesome. Thank you. So, how would a patient who suspects that they have endometriosis but doesn't have a previous surgical diagnosis of endo get an appointment at Mayo?
Yeah, so there are multiple, kind of doors that you can enter Mayo Clinic care from. If you're coming from the outside and you simply reach out directly and for an appointment through the appointment block, it really depends on what you request for the appointment. If you're requesting problems with fertility or requesting problems with pelvic pain, or you have a mass on imaging, all of that will slightly potentially change what door you enter through. But our goal ultimately is for all patients to come in and get an evaluation and have the opportunity to fall through whatever door is appropriate for them to get to the provider that's going to give them the best care. There are 3 of us endometriosis specialist surgeons and many pelvic pain specialists that work together with us in clinic as well. It is a little variable what someone will potentially get scheduled with initially. So certainly if someone is reaching out to Mayo Clinic and they want to see a surgeon initially, I would say a lot of the time that does get scheduled initially. If it doesn't, simply reach out and ask and say, hey, is it possible for me to see a surgeon too at the same time? And usually I think would be happy to do that for you. But in general, if you're going to see a surgeon, it's typically one of the 3 of us, myself, Dr. Cooper, Dr. Khan. We do have another colleague who's joining us who was a resident here, went off to do fellowship and is coming back, and we're excited to have her as well. She's going to be doing endometriosis and fibroids, Dr. Riley Young. So it'll be one of the 4 of us in general that you'll see as a surgeon. And again, if you don't get that in your initial appointment grouping, then just reach out and we're typically happy to get that added on for you.
Awesome. Thank you. So I know this is a question kind of asked in our group quite a bit. So with suspected endometriosis, people kind of ask in there if they should be scheduling like an exploratory surgery with a regular OBGYN, and once it's confirmed, schedule an excision surgery with a specialist, or do you guys do kind of all of that in one being specialists?
Being specialists, we would do that all in one. I think that what can be really difficult for access is depending on where a person is, depending on access to getting to a medical facility with a surgical specialist, depending on, what resources look like for recovery and going to a distance to get care. All of those factors are important. And so I think it's hard to give a uniform answer for every person just because everybody's story is different. Everybody's access to things and feasibility for things is different. I would say in an ideal world, and Dr. Burnett, I'm happy to hear what you think about this too. In an ideal world, you get the right surgery the first time. But I think the important thing is that whoever you see first is safe. And so what I'll usually tell my patients if they've had a prior surgery and things did not get completed, what's important is that that person did not want to hurt you and that they wanted to be careful and safe with you. And so I think that in terms of if you have an initial surgery and there's a look and they see there's endo and they back out and it's too much and then you see a specialist, I think that that's not going to necessarily hurt anything, but it is an extra invasive step. It is an extra recovery. It's extra risks associated with additional invasive procedure. Ideally, you'd have one surgery at one time. When we're doing an exploratory surgery with one of the three, soon to be four of us, we're looking for lesions, and then our goal is to treat those lesions when we find them. And so do it all at one time. There's caveats to that. So if it's in areas where it would drastically change the procedure and we feel you need more counseling, that might be an instance where we don't proceed with something as extensively as we might eventually. But most of the time, what our goal is going to be to fully plan ahead and do everything that we need to the first go. The other thing that can be tricky with endometriosis is we're all taught in residency and in medical school even that it has a specific appearance, and people who actually take care of endometriosis and who stay up to date on the literature on it realize that that's not true, right? There's many different phenotypes that endometriosis can have, and so identification of subtle lesions varies from provider to provider. And so for some of those more subtle spots where it's not as extensive and obvious, it really is more beneficial to try to get with a specialist if you can, just because it might affect their ability to actually identify lesions, not just treat them, but also find them in the first place. What are your thoughts, Dr. Burnett? It's kind of a difficult question to answer.
Yeah, I would echo all of the things you said, and I would simply emphasize we do not have enough access to endometriosis specialists at this time. Okay, we simply don't. If every patient came this year that needed to have a surgery with an endometriosis specialist, we just wouldn't have the volume. And that's evidenced by our wait times just to get in and see us with the volumes that we get. The unfortunate thing is as Dr. Cope said, everyone who does endometriosis surgery, whether a generalist or not, they're doing the very best they can with the training that they've had. And we certainly appreciate everything that everyone is doing to try to help people with endometriosis. That said, it's just not necessarily the same level of care that you will get going to a generalist versus going to a specialist, particularly with as Dr. Cope said, identification of subtle lesions. I do not trust a generalist's operative report that says I looked and I saw nothing. Okay, I do not trust that. Because I've seen too many times, and I've seen in my own training where I was told it was nothing, and then I saw an endometriosis specialist who did it and did it right and was excising very subtle things that I've been told previously were nothing. So we don't live in an ideal state. I think everyone's doing the best they can. I wish we had more access. I think certainly my preference, if it were possible, would be everyone would get their first surgery with an endometriosis specialist so that we're not doing 2 or 3 or 4 surgeries before getting to that point, and really not managing other pain causes too and focusing on, oh, did I get the right surgery? Okay. So yeah, I think I'll leave it there. If there are any follow-ups, I'm happy to address them too.
Yeah. Another question we got kind of on the same track is, what would warrant like a repeat surgery for you guys? Or like what would, like how long, some people ask like how long excision lasts. I know that changes from person to person, but what would warrant like another excision surgery for you guys?
So this is a very complicated question, and let me break it down into people who have had an appropriate, what I would consider a full treatment surgery as their first surgery, versus people who have not. And a full treatment surgery in my book is with an endometriosis specialist who knows how to identify all types of lesions and aggressively treated all visible lesions. If you had that type of surgery, okay, the goal is to minimize repeats of that type of surgery, okay, for 2 reasons. Number one, if your pain recurs rapidly after that type of surgery, it's a sign that doing that same surgery again isn't really going to give you any additional longer benefit. Okay. If I took all the disease out, if I aggressively excised it and your pain's back in a year, we're not going to do surgery every 1 year. That's just not a appropriate level of treatment in that particular scenario. So if you have a prolonged improvement in symptoms with a good surgery, then I would consider a repeat surgery. We're talking 2+ years of significant improvement. To me, that would be prolonged. If you have a short-term improvement, less than that, then you need to A, look for other causes of pain, number one. B, let's just say it is just endometriosis that recurred rapidly, which can happen. Okay. I know there's a lot of different messaging about excision surgery and whether it can come back or not after excision surgery. I am here to tell you it can. I'm here to tell you the data is limited. And a lot of the data that I see doesn't exactly address this question specifically because we don't do a lot of second look laparoscopies. But it can recur. I've seen it recur even in areas that have been completely excised before in under a year. So I know it can occur. I certainly agree and believe that excision surgery is superior to ablative techniques, particularly for disease that isn't just on the surface. But if you have only a short-term improvement, doing the same thing again isn't going to work, or you need to look for other causes of pain to treat at the same time. Doing a second surgery, which might involve addressing other causes of pain, might be something to do in the short term if all other causes of pain are also addressed. So are we addressing the uterus in one way or another? Are we addressing the pelvic nervous system or something else? There are other things we can address, but doing the same surgery again, not so much. If you had what I would consider a unknown or an incomplete surgery, you know your provider didn't fully excise all disease, or they saw stuff, they didn't treat it, or they burned stuff instead of excising it. I believe all of those people do deserve a complete excision surgery while also treating any potential other causes of pain. Okay, so it's not always the case that endometriosis is a cause just because we're not sure it was an endometriosis specialist. Sometimes it is. And it can be very, very difficult to tell the difference between those things. And so that's, again, one of the reasons we have a multidisciplinary approach where we try to do multimodal therapy, treating multiple causes of pain at the same time. But if your surgery was either an incomplete or an unknown category surgery, I do think it's super reasonable to consider a repeat surgery to have at least once excise all the disease.
Awesome. Thank you. Go ahead. Do you have something to add?
No, I was just going to say I agree with Dr. Burnett. That's the difficult part, is knowing what was done the first time, I think, is kind of where we start. And then also assessing for other pain generators to make sure that we're not missing anything else that might not have been addressed with the first procedure in the first place. Mm-hmm.
Awesome. What are other like medical management that you guys do for people that are still having pain?
It depends on what the pain is from, I think. One of the first things we want to assess is, what is their hormonal suppression like? Unfortunately, I know that there's a lot of people who can be sensitive to hormones or have side effects with hormones. Unfortunately, just with endometriosis treatment, we don't have really great non-hormonal options to really target the disease. There's potential other, targets that have been identified and reported in the literature, but as far as actual approved medications that we can use or medical interventions that we can use to target those, we just don't have them available to us, unfortunately. And so first and foremost, checking to see, what have you used before for hormonal medications? Are you a candidate for hormonal medications? Do you tolerate them okay? What are your other goals in terms of fertility? Is it going to be something that will impede fertility if that's a goal, an active goal for you? And so talking about all of those things is kind of the first step. When we're thinking about treating other pain generators, there are certain things that aren't going to be addressed with medications. And so do you need to do physical therapy? Do we need to think about other potential things that are going on as far as like a bowel regimen? Is there a GI component to symptoms? And then also the nervous system. Central sensitization is when the nerves essentially start to sense pain when it shouldn't sense pain. And that's something that's very common, especially if pain's been there a long period of time. And so using medications that are called neuromodulators that affect that component of pain is another thing that we will oftentimes do, particularly if we've optimized other things and we're still not getting benefit. Anything to add to that, Dr. Burnett?
Well, I think that broadly covers it. There are, I think, keep in mind, endometriosis as a cause of pain. Yes, endometriosis causes pain, but pain is a disease that's almost a disease by itself. Okay, it can exist outside of endometriosis. It can be triggered by endometriosis and continue without endometriosis being there. Pain is really a phenomenon we don't understand very well, but what we do understand about it is that once it is triggered and sets up shop, it can continue to generate itself, even without something causing it in the pelvis, for instance. So really, understanding that aggressively treating endometriosis and other causes of pain, like irritable bowel syndrome, chronic bladder pain, all the things that Dr. Cope mentioned, whether or not those were triggered initially by endometriosis or are caused by separate disease processes, our goal is the same: treat all the endometriosis, treat all the comorbid pain conditions to make someone feel as good as they can.
Yeah. Can you guys explain a little bit more about how centralized pain affects people with pelvic pain relating to endo or other things?
Sure. Central sensitization, also known as visceral hypersensitivity, also, the disease process fibromyalgia. And in every single specialty, there is a chronic pain component, whether that's TMJ disorder, whether that is whatever it is. Every medicine specialty has a chronic pain disorder. We like to lump things into boxes because that's what we do as specialists. I'm a gynecologist, so I treat gynecologic chronic pain, but the brain doesn't really work that way. Pain is a central phenomena. Okay, pain is a central phenomenon. What do I mean by that? Pain may be triggered in the body, in the areas where we find the pain or feel the pain, but it is actually sensed in the brain. When you hit your toe with a hammer or you stick your finger with a pin, you might notice there's a slight delay before you feel it. We can actually react to pain before we feel the pain. And that's because that sensor has to go into the brain, get processed, and then our brain tells us what we feel. So there's a little bit of a delay between that sensation and the feeling because of processing. And that processing is very important to understand how pain affects us. When the brain has been exposed to pain for any length of time, and in most of the studies, we see it as short as 6 months, okay? Repeated pain over 6 months, which can be as simple as painful periods. We see these two processes, we call them allodynia and hyperalgesia. Fancy words simply to say we feel painful stimuli as more painful, and non-painful stimuli, things that shouldn't be pain, start to be felt as painful. So for instance, if my uterus cramps because I have my period, and for someone without chronic pain or endometriosis, that might be a 2 out of 10. Someone with persistent pain for more than 6 months, or increasing period pain is going to sense that same physiologic cramp at maybe a 4 or 6 out of 10. In addition, if all of us pass gas through our GI system and we actually don't notice it, our brain does. It senses it and it says, oh, that's just gas. Don't sound any alarms. Don't even let Dr. Burnett or Dr. Cope know that gas is passing. But when we have pain in that area, the brain is more likely to say, oh, we have a signal, sound the pain alarm, because it could be pain that's coming from the same area. So with continued pain, the way the brain processes that pain goes awry, and it goes in the wrong direction, amplifying the pain and causing more things to be sensed as pain that wouldn't originally be sensed as pain by that person's body. And once central sensitization has really started, it starts to limit the effect of taking out or treating peripheral pain, meaning I can sometimes do surgeries and remove uterus, ovaries, endometriosis, everything, and you will still have pain because that pain is no longer needing to be triggered by what's in the pelvis. It's being processed and abnormally recreated centrally. And this is really one of the most challenging things, I think, in our practice to treat. And we go down the same algorithm. So we're always going to treat all of those peripheral pain generators, meaning the endometriosis or the constipation or the pelvic floor or whatever else it is. But when we've treated all of the peripheral pain generators, we need to start thinking about, okay, is there a central component here? How do we make someone feel better, even when it's abnormal signal processing that may be contributing it from the brain centrally? Now, please understand, this is not me saying the pain is in your head. Technically, all pain is in your head, whether it's my head or your head. Yes, pain is in our head because that's where we process and sense it. But it is not a psychological pain condition per se that you have a problem and we're not going to treat you anymore. It's just understanding how pain works, how it metastasizes, quite frankly, I think is the best word, how it metastasizes and how we can best try to treat those downstream effects of pain over time once it's kind of the cat's out of the bag in the pelvis.
Thank you. How do you guys approach bowel endometriosis?
A great question. You know, it depends on what part of the bowel, it depends on how much of the bowel, it depends on depth and size of lesions. If it's more superficial lesions in the area of the bowel, if it's involving the large bowel, particularly the rectum, which is probably one of the most common places we would see it, that's something that typically Dr. Burnett or myself would manage on our own. It's something where you can go kind of over the top of the bowel without actually getting into the lumen of the bowel. And that's something that we're able to manage on our own, or even small lesions that go a little bit into the bowel, we're able to remove in part, leaving the bowel in continuity with some stitches. It's when we start to have larger lesions that actually invade into the bowel or in atypical locations that we would work with our colleagues either in colon and rectal surgery or in GYN oncology. GYN oncology, not because we're concerned about cancer, but because they do bowel surgery within our group here. And so it depends on the factors that are associated with the size, location, who we would collaborate with, and also kind of scheduling logistic stuff on our end, who that person would be. And so once we've identified concern for a bowel lesion, our first step is to figure out where is it, how big is it involving anything else, is there anything that looks atypical about it, because that all of those factors may impact how we plan to address it. Now, not everybody with bowel endometriosis requires surgery either. It's something where we sometimes will incidentally find this. They're having imaging for something else. And then a person is told, oh, you have something that looks like endometriosis in your pelvis. There's also people where they have been managed well medically. And then as part of their assessment, we find that they have bowel endometriosis. When we find that, it's about shared decision making and talking about the options of either doing a surgery versus continuing observation. We know that there is a slightly increased risk of developing adenocarcinoma in deep endometriosis, especially larger lesions that involve structures like the bowel. And so in those patients, although there aren't any national or international guidelines to tell us how often to look, we do typically recommend observation with serial imaging, just to watch for any changes over time that might push us to doing something more of an intervention to remove it as opposed to keep an eye on things or medically manage.
I have nothing to add. That was beautifully said.
Awesome. So this one's a little bit more of a detailed question from someone. If a patient has been diagnosed with stage 4 endometriosis by a doctor who isn't specialized in endo, is it worth having more detailed imaging done at Mayo? And do you see a crossover between endo and IBS symptoms, specifically when all GI tests have been exhausted?
Yes. So I would say yes and yes is a short answer. The longer answer is, so we actually published in our group a look at gastrointestinal symptoms and the likelihood of finding deep endometriosis on MRI imaging. And it turns out the exact same questions that we use to identify irritable bowel syndrome are the things that are increasing the risk for finding these deep endometriosis lesions in the pelvis. So yes, 100%. There is crossover there. It can be very difficult to tell the difference between the two if you're not asking the right questions and you don't know exactly where to look. And this isn't something you're going to see on a colonoscopy. This isn't something you're going to see on a CT scan for the most part. Even just not the right MRI and not the right reader is going to miss it. So unfortunately, the overlap is there, and it can be a little difficult to sort out until you've seen someone who really knows what to look for. As far as if you've been diagnosed with quote unquote stage 4 endometriosis, should you get a second look? I would say it really depends on where you are, what your symptoms are, how happy you are with where you are, with where things are for you. Certainly, we're always happy to see someone and do additional evaluation. In general, if someone tells you you have stage 4 endometriosis, I would say there's a reasonable chance there might be more under the surface than what you've been told. So we know if things are stuck together like some stage 4 endometriosis patients have, or if there are large endometriomas, we know those are markers for having deep endometriosis in the bowel or other places, which may be missed on outside imaging. So we're happy to see anyone who has that type of finding, and I think it's worthwhile. But certainly, if symptoms are well controlled and it can be difficult to travel and do all of those things, it's really a judgment call. But we'd be happy to see anyone with that.
And I agree. I think that specialized imaging, as Dr. Burnett said, it's very important in those cases because a lot of the time with surgeries that you've had before, you might not have images from those surgeries or they might be limited. And so it can be really hard for us to tell when we're seeing you where things are because, like Dr. Burnett said, oftentimes the surface, it's harder to tell what's deeper. And so when we know there's markers or you've been told there was severe disease, there could be increased risk for deep endometriosis. We would typically want to do more imaging especially if we're planning on doing something surgically. If we are planning on watching things, it would be more so making, again, shared decision making and what you feel most comfortable with. If we do an additional imaging, typically, if we've been told there's stage 4 endometriosis history, we'd be thinking about doing a specialized MRI to start. In a lot of our patients, in our MRIs, sometimes it can be even with the specialized imaging we have with that and the specialized readers we have, it can still be difficult to tell sometimes what the extent of involvement of structures is. And so we've started to implement specialized ultrasound as well to help augment our MRI findings in some of those instances to provide the most complete information for you to help with decision making and planning as best as we can too.
Okay. What strategies do you guys use to reduce adhesions to form?
See Dr. Co's face.
It'd be the same answer what you say first.
So, here's the truth. Prevention of adhesion formation, most of the data we have on that is related to open surgery, okay? Particularly with many of the named adhesion barriers that are marketed and sold right now. Or they are tested and they use secondary markers. So postoperative pain or other postoperative findings that aren't repeat surgery to look for adhesions. So just up front, the data is a little murky. And we also know that laparoscopic surgery is inherently much less adhesiogenic, meaning much less likely to form adhesions than open surgery. And if you think about a tool that's been used and designed to work in open surgery where there's a high risk of forming adhesions, okay, if we use that same tool when there is a low risk of forming adhesions, do you get the same outcome? And that's a really difficult question to know the answer to, because the answer could go either way. Maybe it helps, but there's also a possibility that using a tool that helps prevent adhesions in a high risk scenario might actually increase adhesions in a low risk scenario. So it really, at this point in providers doing laparoscopic surgery, honestly, it is a judgment call on what to use and when to use it. In general, my personal preference is I do not use adhesion barriers, except when I feel that it's a high risk scenario for adhesions, particularly myomectomy, or if there's a lot of dissection with planned future fertility, I might put some around the fallopian tube. But in general, I shy away from using them outside of those high risk scenarios because of the uncertainty as to whether it's actually helping or in possibility that it might go the other way.
Awesome.
I agree. And I think that really what's most important is the surgical techniques that we use. And so maintaining hemostasis, limiting thermal damage, these are all things that we do as part of the surgery to in and of itself hopefully reduce risk of adhesion formation, just because, as Dr. Burnett said, especially in minimally invasive surgery, the data is pretty limited as far as the adhesion barriers that were typically used with open surgery. Myomectomy, I agree, that's the most common time I would be using it because I typically address, fibroids and endo as part of my own practice, and that's when we would be preserving the uterus but removing the fibroids, and so there's incision lines on the uterus that we would typically protect in those cases.
Do you guys do any like PRP with adhesions or anything like? I know the CEC in Atlanta does that, so I don't know if you guys.
We do not currently use PRP, no.
Okay. All right. This is another kind of detailed question from someone. What are your thoughts on the drug? I'm gonna butcher this. My Myfembree.
Myfembree.
Yeah, if you have had a hysterectomy but continue to have severe adhesions that need to be surgically removed, is there a point when you would recommend removing the ovaries as well?
That's a tough question. It's hard to give an answer to a clinical scenario without having a lot more details, and I don't think we can really do that in this setting. Certainly, if you have very specific questions about care, we're always happy to see you. Um, I would just say in general, Myfembree and Orilissa, which are relugolix and elagolix, and Myfembree also has estrogen progesterone with it. These are GnRH analogs, meaning they work directly in the brain to partially or fully suppress the ovulatory system, meaning put people into partial or full kind of temporary menopause. And yes, they can be very effective for treating endometriosis-related pain or uterine-related pain or treating fibroids, for instance. But they also have some potential downsides, particularly in younger patients who we are trying to really protect their bones and so on when their bone is actually supposed to be growing rather than staying the same or getting smaller. So in general, they tend to be more last resort medications in my practice, and I suspect Dr. Cope's practice as well. I tend to prefer medications that have a better long-term safety profile, because often we're using medications long-term for one reason or another. Certainly, I do have some patients who fail multiple different medications for one reason or another, and we then go to the thing of lowest risk that we can in that scenario. And sometimes it is a GnRH analog, but I would say in general, it's a third or fourth line option in my practice for treating endometriosis or uterine-related pain.
Okay. Can endo grow back after having a total or partial hysterectomy?
I'll let you go, Dr. Cope.
It can. So it's something that we don't fully understand why, but there is a risk of recurrence of endometriosis even when we've undergone a hysterectomy that can either be with or without ovaries. The recurrence risk is less as opposed to if we just did a conservative surgery excising endometriosis alone, but it's still not zero. And as far as why that happens, where those lesions come from, we fully don't understand exactly what causes endo in the first place in all comers, let alone in these scenarios where we don't have the uterus there anymore. We also don't fully understand why some people are more symptomatic than others in those situations. Additionally, even after menopause, even though most of the time symptoms become less when there's less hormones around, we do know that a proportion of patients do have persistent symptoms. And part of that might be endometriosis lesions themselves feeding themselves. They can express different enzymes that convert hormones floating around in our bodies into estrogens, causing them to be more symptomatic. Or if people will be on hormone replacement therapy after different types of surgeries going into menopause, that's another time where we might see risk of recurrent symptoms. What can also happen is, if you did not have a complete surgery the first time, so maybe there's persistent lesions rather than recurrent lesions. That's something that's a little bit difficult to, you know, piece out sometimes, but that is still something to think about is, was it fully addressed the first time rather than being recurrent? Is it persistent? And that's another thing that's going to depend on the person.
Does endo cause menopause to happen earlier than normal? If so, why?
So in general, endometriosis is mainly responding to hormones, although it is very complex and there's lots of ongoing research showing interplay between lesions and other things through other hormones or messengers. But in cases where endometriosis significantly involves the ovaries, that really is the one scenario where endometriosis may affect timing of menopause. The longer endometriomas or cystic endometriosis sits in the ovary, it's an inflammatory condition and it slowly kind of eats away at the ovarian stroma. So the longer they sit there, probably the more damage they're doing to the number of follicles or the amount of reserve that ovary has. And through that mechanism, certainly, I think it probably is going to affect the timing of menopause. I don't actually know about specific data on that, but we've seen that in patients undergoing fertility treatment and who have decreased ovarian reserve from that fertility treatment. So yeah, that's the one area I would expect.
and depending on the treatments that have been done too. We're getting
Very
more and more
true.
about hysterectomy, particularly in younger patients. Even if we preserve ovaries, there are associations with increased risk of different medical comorbidities that are associated with early menopause and even earlier onset of menopause potentially itself. I think that that's something that we're just now getting more data on. A lot of the papers on that are within the last 5 or 6 years. And so I think there's still a lot we don't understand about that, but that also might impact timing to menopause, depending on what types of interventions you've had done surgically.
And definitely anyone with endometriosis is at higher risk for someone taking out an ovary. We try to conserve that as much as possible, but unfortunately, this still gets done sometimes more often than we would like.
Okay. Kind of back to adhesions. I forgot to ask this after that. After being diagnosed with endometriosis, how do you know if your main symptoms you have with your cycle are actually like adhesions worsening? And what are certain signs to look for with adhesions?
Okay, Dr. Cope, I will take a stab. So this is in the category of things that I would say is very difficult to know what's going on and what is causing what. So unfortunately, we see a lot of patients with adhesions, whether that's from endometriosis, from a previous surgery, from an infection, or something else. And the rate at which people with those adhesions have symptoms is very variable. So I sometimes operate on someone because I'm looking for a cyst to take out and they have no symptoms at all, but we're going after a postmenopausal cyst and they have terrible adhesions and they feel 100% fine, versus, someone who has one adhesion or zero adhesions and has terrible pain. So the correlation between specifically adhesions and pain just really isn't that robust. Now, I certainly do think adhesions can cause symptoms, but I definitely know that they don't cause symptoms in everyone. And then, of course, the question is it just the endometriosis or is it the adhesions that's causing the symptoms? So it's complex. I would, in general, recommend focusing on the symptoms and then strategies to treat those symptoms as opposed to whether it's specifically the adhesions or not. The difficulty with adhesions is, particularly if you've already had surgery to excise all the endometriosis or other treatments, is that doing surgery to treat adhesions, for instance, is typically not recommended by most people because, adhesions are often caused by surgery. And if we do more surgery to take out adhesions, we're still leaving damaged tissue that after the surgery typically is going to stick back together and adhese again. And again, as we talked about with adhesion barriers before, they're far from perfect. So in general, if we do think that adhesions are causing symptoms, we tend to rely more on things like medications that are going to tone down those symptoms, physical therapy to do adhesion release, or other symptomatic management.
Awesome. What is the best method, or is it even possible to rule out a diagnosis of adenomyosis prior to surgery?
Gosh, it's a really tricky one to diagnose. I would say most of the time we are diagnosing based on symptoms, based on exam findings for suspected adenomyosis, or sometimes we can see on imaging. That can be ultrasound, that can be MRI. There are different markers that have been described to help identify adenomyosis, the shape of the uterus, if there's extraglandular components within the muscle part of the uterus that we can see, if there's kind of a thickening of the myometrium or that muscle layer, if there's asymmetry in that. There's different things that we can use as markers on imaging if there's uterine tenderness. But it is something that's not perfect, especially if it is more diffusely present throughout the uterus and more subtle. It might not be something that we're really able to see on imaging, and we're going based on suspicion, based on symptoms or exam findings. And the unfortunate thing about that, too, is really the only way to know for sure if someone has adenomyosis, unless it's very glaringly obvious on imaging, is to actually do something like a hysterectomy, which is a terribly invasive and irreversible diagnostic test. And so ideally, we try to just talk about suspected adenomyosis, or try to look for signs on imaging if we are not planning on doing a hysterectomy either which way. The other thing with adenomyosis, I think that's tricky is even sometimes this might be a point of frustration for Dr. Burnett too, but we might see very obvious findings on imaging, very consistent on our exam. It looks like it at the time of surgery when things are removed, and the pathologist does not comment on it very specifically. And so it really depends on who's looking at the specimens sometimes too. And I think that part of that is if it's a gynecologic pathologist as well. So someone who specializes in gynecology looking at the specimen. And so that also can factor in the diagnosis of it with confirmation. But I, in general, try to think of it more as do we have the symptoms for it, the exam findings for it, plus or minus imaging features is how I think about it. I don't know if you have a difference in opinion, Dr. Burnett.
No, 100% agree. I think focusing on symptoms and treating those symptoms is probably the way to go for most people. Sometimes the imaging findings give us a little bit more direction, but physical exam symptoms, I think is going to get us there most of the time.
Okay. So knowing a hysterectomy isn't a cure for endometriosis, is there a time when one is warranted, and does it help manage endo? Does that also mean less hormonal medications?
Also a tricky one. So first of all, removing a uterus does not treat endometriosis that's in the body. Okay, just to get that off, off the stage. If someone does a hysterectomy or even does a hysterectomy and removes ovaries and then puts someone on estrogen only, which commonly I see people doing, and doesn't treat the endometriosis, the person will still have symptoms. Okay, so hysterectomy is not a treatment for active endometriosis that's not treated. Hysterectomy, we do think it does affect the recurrence rate of pain and maybe endometriosis. We do definitely see a lower 5-year pain recurrence rate in women who have a hysterectomy at the time of surgery for endometriosis compared to those who don't. Okay. Hysterectomy is appropriate for uterine-specific interventions, so bleeding problems. I see an occasional patient who says their bleeding gets better after endometriosis-only surgery, but I definitely do not tell my patients that that's something to be expected. So certainly if you have bleeding issues, just removing endometriosis probably isn't going to fix it for you. And in general, the uterus does cramp. So in the absence of endometriosis, again, if you are someone who had endometriosis, had very painful periods, and your brain is on alert for that cramping around the time of your periods, we know from the data that women with endometriosis feel uterine cramping worse than women who don't have it. And it goes back into that whole central sense of sensation phenomena that we talked about. So in some patients, using hysterectomy to treat bleeding or to treat uterine cramping is certainly reasonable if that's in line with where the patient is age-wise, where they are with risk factors for hysterectomy, etc. And often, sometimes we might do a staged approach if we're not sure, if someone doesn't have bleeding problems and we're not 100% sure if the uterus is cramping and causing problems. We often just remove endometriosis and then see how someone does. To the point of using hormones afterwards, I would say it is more challenging managing bleeding, cramping after endometriosis surgery in someone who retains their uterus versus someone who does not, again, because the uterus can cramp and bleed, and if it's not there, it doesn't. So yes, I do think I find myself sometimes being more aggressive with hormones after surgery for endometriosis when a uterus is still in place. And sometimes not. It can really go either way. It depends on what you use. But I would say, yes, that is a risk after endometriosis surgery. So no, hysterectomy does not treat endometriosis directly by itself. Yes, the uterus does cramp, the uterus does bleed. That can be a challenge in some patients after endometriosis surgery. It can affect how we use hormones, yes, in some cases. Dr. Cope?
I agree fully. And I like that you brought up the thought of a staged approach too, because I think sometimes, for people who, might not be entirely sure about future fertility or even not even the question of fertility, but just I think that the uterus for people can represent a lot more than its function and its parts, right? I think that it's something that for people, it's not like, oh, you need your appendix out. No one mourns the loss of their appendix, or at least most people don't. Maybe someone does. I have yet to meet one. Usually they're like, please take it out so I don't have to worry about it. But when we think about the uterus, I think that it bears a lot more weight for some people. And so we want to make sure that we're respectful of that when we talk about it with patients too, because it's not an easy choice for some people. For some people, it's super easy. For some people, it's a really hard choice. Even if it seems like it might be a pain generator, we've tried other things, this might be beneficial for them from a pain standpoint or quality of life standpoint. It doesn't make it an easy choice for some people. And so I think that that's the other thing, is to try to meet a person where they are, just in terms of that part as well. I think shy of us seeing something like, oh, we're concerned that there is a cancer in your uterus, we do not absolutely have to take it out, or if you're having life-threatening bleeding. Those would be the main reasons we would have to do a hysterectomy. But shy of that, I think that it's about shared decision making and weighing all of those factors together and talking about it.
Lots of good information. How does genetics play a role in endometriosis?
We don't know. I think that what's tricky is with a lot of these factors with endometriosis, we do know that it has a pattern to run in families. People who have first degree relatives with a history of endometriosis are at higher risk of having endometriosis themselves. It's unfortunately not something like the BRCA genes that we can test. We don't have a specific genetic test we can do to say, yep, we're more likely to have endometriosis with this genetic variant. But it is something where if you have a family history, you have symptoms that are suspicious for endometriosis, that does increase likelihood that we will find it. So as far as, what does that mean for, your own children, for your other family members? That's just something for them to be aware of as well, to have a lower threshold, especially when communicating with healthcare providers about their symptoms. But unfortunately, not something where we can say, yep, we're going to send a gene panel and it'll tell us exactly, if you have endometriosis, yes, no, or what types, any of those things. We're just not quite there yet.
Probably as many things are, it's multifactorial. Genes may contribute, environment may contribute, other factors may contribute. But yeah.
I just want to add before the next question, if anyone on the call has any questions specifically for them, you guys can add them in the chat and then we can answer them for you too. We want to make sure we get to everyone's questions. How do higher levels of, okay, I'm going to butcher this word too, androgens, such as seen in testosterone therapy, affect endometriosis? Did I completely butcher that?
Not too bad. Androgens. Yep.
Okay.
So in our bodies, we have many different types of hormones. We have what are called sex steroid hormones, which we think of as the estrogen and progesterone, as well as testosterone and androgens. Testosterone is a form of androgen, and there are many other androgens that are precursors or postcursors in the production of things like testosterone and other sex hormones. Women and people who are born female do have androgens in their system, and so we have a mix of a variety of hormones. In general, most of the literature suggests that testosterone is suppressive of endometriosis, meaning like progesterones or other things that we use to treat endometriosis symptoms, testosterone is likely going to quiet it down and decrease its symptoms. Don't have really a lot of data on that, but there are a couple studies looking at that kind of in the lab. And then other androgens I don't really have much data on. I don't know, Dr. Cope, if you have anything that you know beyond that for other androgens, but I would suspect maybe suppressive, maybe not, depends on where it is, if it's a precursor, how strong an androgen, hard to say. We can't currently measure any hormone level and say how that's impacting endometriosis. So we don't take body levels or blood serum levels of hormones to look at factors for endometriosis treatment or response or anything like that. Firstly, because we don't know that that's a significant independent risk factor, number one, and number two, it really doesn't change management because our tools are to suppress, really not to, we can't micro manipulate our own hormones specifically. So great question. I think super intriguing to think about, but not a lot of specifics I can give on that.
And I think it's an unfortunate thing that we just have very limited data actually looking at outcomes too. I think that, it's something where hopefully we'll get a better understanding of it in the future because it does affect our patients, particularly people who are already in vulnerable populations who may be on HRT with testosterones and other androgens. And so it is something that as we continue to have more data, hopefully we'll have a better understanding of what that means for our patients who also have endometriosis and maybe on these medications.
Awesome. I have a couple more questions and then we'll get to the ones that are being asked in the chat. Do you allow residents or fellows to perform any portion of the surgery, and who typically assists you during surgery?
That's a great question. And I think it depends on multiple factors. So, being at the Mayo Clinic, we are an academic institution. That does mean that trainees are involved in your care when you come to see us as patients. As far as the degree of participation in that care, it varies depending on the learner, it varies depending on the complexity of the surgery, and it varies depending on other factors, dependent on the day. I would say in terms of who we have assist us in the operating room, we also oftentimes will have surgical assistants. And so these are separate from trainees where that is their job. They have learned how to be assistants in the surgical environment. And so that might be helping with positioning or bringing patients to the operating room. That might be withholding things, not so much doing the procedures themselves, but being an extra hand to assist us during the procedure. As far as what involvement fellows and residents will have, at least in my cases, I'm there the entire time. I don't run two rooms. I may be rarely pulled out for an emergency that I need to address, but I will be there for all vital components of the surgery, and I do not have them operate independently without me being present there. And so that is typically how I manage a team like that. In terms of how much people are doing, a lot of the time, particularly with complex cases, I'm doing the majority of the work. And once things are normalized under very specific direction with me right there, we are doing things together, or might be doing parts that are more kind of common as part of their training. But it's a mix. And I would say that it's hard to give a universal answer just because it's going to be really dependent on the scenario. In any case, they're being supervised very carefully. We're there the entire time. And we're not having them independently make decisions. We're usually being very specific and telling them what to do and where exactly to do it and showing them is typically how it would go. Dr. Burnett, do you have anything else to add to that?
Nothing to add, really. My practice is very similar to Dr. Cope's, very hands-on. I don't run two rooms, always present, do the vast majority of the work, and residents do what's appropriate, fellows do what's appropriate under direct supervision. There was one other thing I was going to mention. We are a teaching institution, because we need more providers who are going to take good care of women in the future. And if we want the continued care for our daughters and our daughters' daughters and other people who have diseases like endometriosis, we need to train the current generations of doctors. And that doesn't mean experimenting on people. That means very careful joint surgery where there's supervision and appropriate portions are done by people who are trained and approved to do them.
Got to start somewhere. So I just have a couple of questions about research. So is there any new research that can tell us what the cause of endometriosis is? And does this research lead to any advice or on prevention?
Gosh,
Go ahead, Dr. Cope.
oh,
I think you're at the most recent conference. So what do you have?
actually pretty jazzed about it because I love SRI. So I just got back actually from Vancouver. There's a national, or I guess international group. It's called the Society for Reproductive Investigators. It's awesome. It is super nerdy. It is very basic science, and it is just so awesome. Everyone gets super excited to talk about their research. And what's great about it is it's very collaborative, and it's something where we all get to learn from each other. I think there's no egos really there. It's a great conference. I'm very biased because I think it's just wonderful. I had a great time. And I think that as far as where I see endo research going, As Dr. Burnett mentioned before, it's very complex and it's oftentimes thought to be multiple factors that all overlap. So I don't know that we're ever going to have a one answer. This is 100% the only thing that causes endo because it's probably multiple pieces. Areas that are getting investigated more include immune factors. So, how does our immune system interact with these lesions when they're present? Does it affect how they're formed? Does it affect different flavors of endometriosis as far as superficial versus deep versus endometriomas? Does the microbiome interact with that? That's something in our own group that we've started some pilot studies looking at the role of the microbiome in the GI tract, in the vaginal tract. How does that interact with the immune system? How does that affect the development of endometriosis and how it presents? There's also research looking at stem cells. Are there stem cells involved with this process to form lesions? There are different genome-wide association studies looking at overlap of endometriosis and other chronic medical conditions. And are there linkages there that might increase risk for those factors to develop both independently and together? And I think that as far as how that plays into treatment, part of that is trying to find different targets, right? So not just are we figuring out how endometriosis happens, but are we finding factors along those complex pathways that are not hormones that we can try to put interventions on that are more targeted to endometriosis without the same systemic side effects that hormones can carry. One of the things that I think is great, even just seeing from the past, couple of years, even the conversations about endo and research, is what historically has been looking at is there endo, yes or no, which is a very limiting question, is people are actually starting to ask, okay, well, we know endo is not a yes or no thing, right? There's stages of endometriosis, there's different subtypes of endometriosis, there's different phenotypes of endometriosis, how it looks. There's different types of symptom profiles that patients will have. There's different overlapping pain syndromes and other medical conditions that people have. And so I think recognizing the heterogeneity of the disease process, how mixed it is, and actually trying to get into understanding those differences is also something that's very important and something that the research community is actually starting to tackle rather than, oh, I have this tissue from my surgeon that I work with and I don't know any of the clinical details at all. People are starting to ask those things and recognize the importance. And I think that taking those questions into account from the get-go is going to allow for better translation into what that means for patients and patient level care. And so I think that we're still in the early phases for a lot of that, which is frustrating for patients. It's frustrating for us. It's frustrating for researchers, but I do think that it's an exciting time to be involved with research for endometriosis because people are starting to recognize it and respect it more. And I think that it's something where we're starting to ask the right questions, not just endo, yes or no, but also trying to look within the breadth that is endometriosis too.
I'm just going to stay off spotlight, but I'm just going to read you guys these questions. So the first question is, how often do you use IUDs for endo treatment?
I love IUDs. I think they are probably our best delivery method for using as little hormone as possible to get hormonal benefit either to the uterus or reducing risk of recurrent pain related to endometriosis. So in general, I like them quite a bit. They have their downsides, certainly. Some people still get systemic symptoms with them, even though it's a very minimal dose that we think of as more local than systemic. And sometimes people with central sensitization, I find, don't tolerate them in the uterus quite as much. They feel it as crampy. But those things aside, I do like them and use them a lot.
Same.
Awesome. How complex can endometriosis be to remove?
Very.
I feel like that's a loaded question a little bit.
So let's just put it this way. There's stage 4 endometriosis, and then there's stage 4 endometriosis, and then there is stage 4 endometriosis. Okay, so even there are different staging systems. If we look at the most commonly used, which is the ASRM staging system that most people probably hear of when they think stage 1, 2, 3, 4 endometriosis, even in that stage 4 endometriosis, there is a wide variety of how difficult the surgery can be. And it's challenging surgery. It's difficult surgery. I am now 9 years, coming up on 9 years into my post-fellowship practice. And I am still learning new things and new ways to do things. I would consider myself very, very good, proficient, excellent, complex surgeon. But I'm still learning new things because this disease just always comes at you in different ways, and gives you more opportunities to learn and grow. So yeah, it's tough surgery. It is not for the faint of heart. Dr. Cope is an excellent surgeon. We worked together for quite some time, and I've seen her hands and her skills, and she's excellent. And she would, I'm guessing, tell you the exact same thing. We learn day to day, even though we are top tier as far as surgeons addressing this disease. It is a challenging disease, which also honestly makes it fun and interesting, because no surgery is exactly the same. Every day that I operate, it's a different surgery. And yeah, I use the same processes and tools and approaches, but I have to vary them, and change the tactics to address different aspects and interesting facets of the disease. So surgery is my hands today. I was operating today, and my thumb is hurting. So yeah, that's surgery.
Yeah, I agree with Dr. Burnett fully. I think that it's something where you can't say that every single case is the same because they're not. I think that what we learn in training is how to identify the disease, what are the safe principles that we can apply to help us in all of the variety of different settings, because you're never going to see the same case twice. And I think that it's also too is that just endo, or is it endo plus fibroids? Is it endo plus multiple prior surgeries? Is it endo plus transplant? Is it endo plus Mullerian anomalies? There are so many different flavors that can add on different layers of complexity to what we're doing. And I think that it makes it rewarding and interesting for us, but it also does make it challenging. And I think that no single procedure is the same for each individual person, but that's what makes it a joy to get to be a part of in patients' care stories too. But it can be very complex, very challenging.
Well, I think I speak for the whole community. We're glad that you guys chose to deal with endometriosis and all the complexity of it. If you have infertility with endo and are headed down the IVF path, is it best to do egg retrieval before endo excision?
So I think I'm going to first say we should turf this question to one of the fertility experts. I know that Dr. Khan will be coming on. Did he already come on, or is he coming on? He's coming on.
I'm just going to spotlight myself again. Dr. Khan we did already talk to him last week, and we have the recording. We are going to put that on. He did answer a question very similar to that. He answered a lot of fertility questions. So yeah, we'll just skip the infertility ones, and you guys can watch the Dr. Connor.
We'll give you the very short answer, which is talk to your fertility specialist about your specific case, number one. Number two, limited disease, mild, minimal disease. I don't think they see a significant change in fertility outcomes by doing surgery before doing IVF. And even in deep disease, Dr. Cope, you've worked with Dr. Khan more recently than I have, but specifically for enhancing fertility rates, I don't believe excision of deep disease increases IVF outcomes specifically. So I believe Dr. Khan does surgery for deep endometriosis mainly for symptoms rather than to specifically change IVF fertility outcomes.
I was just asking Dr. Ainsworth, who's one of Dr. Khan's colleagues in the RAI division the other day, because I was seeing someone where the primary goal was for fertility. And I think it depends on if you're planning on proceeding with fertility treatments or not, as far as how you'll be counseled for part of it. And then as far as IVF outcomes, part of it depends on kind of what the type of disease you have, and also kind of the size of endometriomas and how retrievals are going to go is the other piece.
Endometriomas are a separate piece. And I did see a question in the chat about endometriomas and size and fertility. But yeah, we can get to that too.
Yeah, and then the other piece too is like, do you have any obstruction of the tubes? Is there any sign of blockage of the tubes? Because that can increase inflammatory markers that impact IVF outcomes. And so I think it's hard to give a universal answer because it's really going to depend on the disease process that's going on.
Okay. So someone said I have read that some have been told what stages they are. How is that determined, and why do some doctors not use stages?
So The first question is what staging system? So we have multiple staging systems that can be used. The most commonly known is the revised American Society, revised ASRM, American Society of Reproductive Medicine staging system. It's an old one. And it's but it's the most widely known if you simply say endometriosis stage, but there are multiple others, and those others, a lot of them were developed because that old one doesn't really predict anything very well for us. It doesn't predict how fertility is going to go very well. It doesn't predict what's going to happen after surgery. It doesn't predict how you're going to respond to medications. It doesn't really predict much of anything with any amount of validity to use to be really useful. So it's more a way that we just talk to each other about what the findings were, so we can easily use it as a shorthand to say, oh, this patient had this much endometriosis. But there's also the Enzian staging system. There's the fertility index. There's a few. There's now the JMIG staging system, and there are others that I'm not even thinking of. So yeah, each of them kind of tries to answer a specific question and give specific information about whoever was staged. Did I miss something about the question?
A lot of those are based on surgical findings too. That's the other thing. And so, with the JMIG or AHL staging criteria, they also have an ultrasound based staging system. But I think with any of the staging systems, there's going to be limitations. We know, for example, that as Dr. Burnett said, symptoms and outcomes don't correlate with stage for a lot of these things. And so it's something where it depends on who you see, what staging system they may use. And a lot of the time it's just to communicate findings to the patients, but then also to other providers who might be giving care to these patients too.
Okay, thank you. I am going to skip the question about the MRI. Dr. Khan also touched a lot about the MRI machine at Mayo. Can endo in the abdomen impact the spleen? What are scenarios of why the spleen would need to be removed? How does it impact your life if it is removed?
So what's interesting about endometriosis is there's a lot we don't understand about it, but part of what we don't understand is it can go to a variety of different locations in the body. It's been described in most, if not all, areas in the body in the literature. And the spleen is an area where we don't have a lot of data saying that it goes to that space, but I'm sure that there could be case reports of that. I don't know, Dr. Bennett, if you've found one. Another time where it might be impacted would be if it's in that area of the diaphragm or tucked behind there. The spleen lives kind of in your left upper quadrant near where the diaphragm is. And so if you have lesions that are tucked behind there, for safety, it might be something that is impacted as far as the spleen vasculature or the spleen itself. It's a very vascular organ. And so my guess would be why it would need to be removed in those cases would be if it was a safety concern, or I guess if there was disease invading into it, but that would be something we would usually be collaborating with a hepatobiliary or a general surgeon to assist us with those cases, or maybe even someone in GYN oncology. I don't know, Dr. Burnett, have you had experience with that yourself?
I've seen a couple spleens that have things on them that we were not sure if it's endometriosis or not. And then the question always is, biopsying a spleen is not something you do because it's very vascular, as Dr. Cope mentioned. So it's either you remove the whole spleen or you leave it alone pretty much. So the spleen it has immune function. There are some downsides to removing a spleen. I'm not going to specifically speak to them now because I'm a gynecologist, but certainly talk to your local doctor, your primary care physician about that. So some things about how you respond to vaccinations and so on are mediated through the spleen as well. So it's, as with everything, a shared decision-making, risk versus benefit kind of conversation if that's suspected. I don't know, someone had once told me that the spleen is the one place that we don't have a case report for endometriosis. I don't know if that's still the case, but I do know it's probably just because people aren't going to biopsy it. So when you see it, like as in my two patients, are you going to go after the diagnostic cancer or not? So yeah, the spleen is tricky. I think that's a very unusual kind of presentation that really needs to be taken on a case-by-case basis and take into account the whole picture.
Okay. Any thoughts on patients that have PCOS and endo? Any different treatment you may prescribe?
My first thought would be, as in patients who are on hormonal suppression or birth control pills, would be I wouldn't necessarily expect the usual cyclic pain symptoms. PCOS, we tend to think of it as inadequate or irregular ovulation. So you're not getting as much progesterone, you're getting more estrogen. So really paying attention to the symptom profile. We see, PCS is fairly common, endo is fairly common, so there is overlap between the two. I don't know that there's a direct correlation between the two, though. Dr. Cope, do you know much about that?
No, I think like Dr. Burnett said, they're both common. And so it's not uncommon for us to see overlap in our patients. I agree that, the cyclicity component or how symptoms are in cycles can vary in those patients because you don't have regular cycles a lot of the time as a presenting symptom of PCOS. The other thing that I think about in those patients in terms of care planning is separate from endometriosis, the risks associated with PCOS. And so PCOS does put you at higher risk because there's less consistent shedding of the lining, there's more overstimulation of the lining of the uterus. You're going to be at higher risk of things like hyperplasia or precancer changes and even cancer of the uterus. And so making sure we're protecting the lining of the uterus in addition to thinking about management of symptoms is also very important. And then the other piece with it is just working with your primary care provider to make sure you're up to date on screening for things like diabetes, cholesterol levels, all of those things, metabolic syndrome, you'd be at increased risk for in the setting of PCOS. And so making sure that you're being screened for those things separate from endocares is very important if that has not already been done. And so not forgetting about the components related to PCOS specifically by focusing more on kind of the other piece of what's going on.
Okay. The next one is there a size of endometrioma that you would recommend to remove versus monitor? What signs/symptoms do you consider when making this decision?
So the classic teaching really is endometrioma size is related to risk of malignancy. And so when endometriomas get above 5-6 centimeters in size, we should consider moving forward with surgical management to reduce the risk of developing malignancy or finding malignancy that's there. I would say as imaging has gotten better and better over the years, I've taken out a lot of larger endometriomas, and I don't think I've ever seen a cancer or precancer in a patient who didn't have suspicious findings on imaging. So I've become a little more comfortable watching some of these endometriomas when imaging is clear and informative, and if in patients who particularly are adverse to surgery or don't have many symptoms, then I think there is room for speaking directly with your doctor about where things are and how to move forward. But that said, it is important to know, as Dr. Cope mentioned earlier, that endometriomas are associated with malignancy. It is a low rate, we think somewhere around 2-3%. So that's very low, but it is something to be aware of as we think about their management, the risks and benefits of operating versus not operating.
Okay. So the next one is how long, if any, is the hospital stay at Mayo after excision surgery?
It depends on what all we're doing and it depends on what type of surgery is done. In general, if it is an excisional surgery, we're not doing anything involving the bowel. Even if we do a hysterectomy, a lot of the time it can be a same day discharge from the hospital. Obviously, we want to make sure that that's safe. We do what's called enhanced recovery at Mayo Clinic. And so, working with our colleagues in anesthesia before, during, and after the case, we're trying to optimize outcomes in terms of pain management and limit the need for staying in the hospital as best as we can for people to avoid risks of being in the hospital and just the burden of having to be in the hospital. If we are doing bowel work, it depends on the degree of bowel work, what type of procedure is done on the bowel, if a person needs to stay in the hospital or not. On average, even if we're needing to do a resection of bowel, for most of our patients, with the minimally invasive approaches that we use and the enhanced recovery protocols that we follow, for most of our patients, that's maybe 1 to 3 nights in the hospital on average. But even still, for some people, if it's minimal involvement, minimal work on the bowel, you may still be able to leave the hospital same day. Of course, we want to make sure it's safe. And so part of that is making sure that you have access to emergency care, that you're not way out in a rural space where you have limited access to a hospital. The other thing we want to make sure is that pain's under adequate control. So unfortunately, surgery does cause increase in pain, but we want to make sure it's at a tolerable level for you and that you're able to still get up, move around, do the things that you need to do. And then we also want to make sure people aren't having issues with nausea. The other thing with our surgeries is, as we talked about before, they can be really complex. They can be a long day. And so if it's a really long day, it's late recovery, you might not be safe to go just because it's been a long recovery for you and you're still too tired and still too sedated from the anesthesia. And so we individualize it to the person. But I do feel that thankfully most of our patients don't require a hospital stay. And if they do, it's oftentimes short. I don't know if you have anything else to add, Dr. Burnett, to that.
That covers it for me.
Okay, one last question for both of you. What has surprised you the most about endo?
What has surprised me the most about endo? I would say what has surprised me the most is the different phenotypes, meaning the different ways the disease can look when you either image someone or when you go in and look laparoscopically. It is just a varied disease. It can, I see occasionally this thing that looks like velvet endo. I see like a once or twice a year. We see patients who have no superficial disease and just a solitary nodule in their bowel. We see patients who have all superficial disease. We see patients who have these peritoneal inclusion cysts with endometriosis. We see patients who things are all stuck together with bowel disease, and we see patients who nothing is stuck together with bowel disease. And the variety and variation that we see as one of the areas of research Dr. Cope was mentioning, we just do not have great explanations for at this time. And I'm really excited to see that we get some of those answers trickling in. But it is still at this point, I think, one of the most surprising things for me.
Me too. I think the heterogeneity of the disease process and the symptoms that people experience, it's something that we still don't really understand very well. And I think it's something that makes it interesting to try to understand better. I think the other thing that is really interesting to think about is it's classified as a benign disease, right? It's not cancer, it's benign, but it behaves in a way that seems very cancery, right? It goes to places it shouldn't, it invades structures, it doesn't follow the anatomic rules that we would like it to follow. And so I think that just the complexity of it is surprising in the different ways that we see it every day. And I think that hopefully we'll get to a place eventually that we understand those things better so we can optimize care for our patients and individualize it even better. But it is something that we're still learning more about all the time, and it's surprising all the time. I feel like that we can't predict very well, what we're going to find. That's something that we both get asked a lot. I imagine you too, Dr. Burnett, were having OR teams. They're wanting to know kind of what to expect for the day, how long things are going to be. And a lot of the time we can have a good guess-ish, but we really truly don't know until we actually are looking what we're going to find. And I think that that's something that can be a surprise every time, just because we can have all of the best tools, do all the best prep work, try to go based off of symptoms and history, but there's just a lot that we can't predict until we're there. And I think that makes it interesting and makes it challenging for our patients.
I've got one more that I thought of, and that is seeing patients who have significant disease and don't have symptoms. There's some patients who I think certainly symptoms are minimized either by others or otherwise, but I see occasional patients who truly have no symptoms. And I see occasional patients who, for instance, have a large bowel invasive lesion that was present before someone operated on them. Someone operates on them, they feel better for a few years, but that person didn't take out the bowel lesion. And I see the same bowel lesion there when I re-image them again, and now they have new symptoms 2 to 3 years later. How does that work? Okay. And that just tells you how little we understand about pain and the processing of pain, and of this disease process. So, so much to learn, and glad to be able to be on this journey with all of our gracious patients.
Well, we're very thankful you guys were able to join us tonight. So thank you so much for joining us, and everyone on the call, thanks for joining us. It was so great to talk to you guys tonight and get all of our questions answered.
Everyone have a good night. Thank you so much for having us.
Thank you so, so much. Thank you for sharing this time and space with us. And thank you for trusting us to talk with you guys.
Thank you so much. Have a good night, everyone.